Dr. Valderrabano is the head of our EP service, and these last two talks, both he and Dr. Lin are getting a little outside the valve world, but into sort of complementary structural interventions. And he's going to talk to us about the left atrial appendage occlusion procedures and devices, indications and expectations. Miguel?
So it's a little bit of a change in topics, but we're going to be talking about left atrial appendage occlusion and their role in stroke prevention in atrial fibrillation, indications and expectations. This is a tough set of issues to discuss because the evidence and the dogma is still not settled, and there's still a lot of uncertainties. But as a preamble, we need to know that atrial fibrillation has important prognostic implications. It at least doubles the risk of stroke. In certain populations, it can multiply the risk of stroke up to times 7. And that's associated with an increase in mortality. And we know that the vast majority of strokes in atrial fibrillation come from thrombi that develop in the left atrial appendage. The left atrial appendage is this sac-shaped structure in the left atrium. And during atrial fibrillation, the lack of contractility in the appendage leads to stasis, and stasis leads to thrombus formation, and thrombus formation may stay there or embolize and give you strokes. So this is the mechanistic paradigm that we have all embraced. So how do we prevent strokes? Well, we give systemic anticoagulation. If we thin the blood, we prevent clot from forming in the appendage, and that's great. The problem is blood thinners thin the blood everywhere, not just in the appendage. If we choose systemic anticoagulation, there's Warfarin and the novel oral anticoagulants. All of them have shown effective prevention of strokes in AFib. But if we choose a local therapy, we can choose to close the appendage. And the idea being that if we lock flow from coming out of the appendage, we would prevent thrombi from leaving and embolizing into the cerebral circulation. And there's a few strategies. I will devote most of my time to the Watchman, which is the one that's FDA approved. Other devices, Lariat, AtriClip, Amulet, there's tons of other devices being studied, have not been FDA approved yet. And the key issue, the key concept that I want to emphasize on everybody is that selecting the right strategy requires individualization of the risks and benefits of each of these strategies. In general, who needs appendage occlusion? You have to have a sufficient risk of stroke. Not everybody with AFib has equally increased risk of stroke, and I'll go over how to assess that. And the risk of stroke has to be put in the context of, how many years of life does the patient have? If you have high risk factors for stroke and you're 40, we're looking at least 3 decades, 4 decades of anticoagulation on one side, and 4 decades, if we close the appendage successfully, 4 decades of freedom from anticoagulation. So that's a big deal. But if you're 96 and you have a high risk of stroke, you may die from other things, and therefore the risk of stroke may not have the same meaning. And patients with atrial fibrillation have appendage-dependent risk of stroke and then non-appendage-dependent risk of stroke, and that's extremely hard to discern. And that's something that I would expect that in the next 5-10 years we will learn more to do a better job. Patients may have significant limitations to comply with oral anticoagulation. Patients may have bleeding. Patients may have financial issues that prevent them from buying the new anticoagulants that are very expensive. And if you're going to close the appendage, the patient has to have an acceptable procedural risk. And of course, if the patient has indications for anticoagulation other than atrial fibrillation, then there's no point in closing the appendage. So let's just go step by step. How do we assess the risk of stroke in AFib? A priori, the higher the risk of AFib-related stroke, the greater the benefit of appendage occlusion. But we assess the risk of stroke using this CHA DS scoring system, which include a history of congestive heart failure, that is the C. The H stands for hypertension. The A is H more than 75, you get 2 points, or more than 65, you get 1 point. You get 2 points if you have a prior stroke or a TIA or a systemic embolism. 1 point if you have vascular disease, and unfortunately 1 point if you're female, because females have a greater risk of stroke with atrial fibrillation. Now, I will ask you, what is the role of the left atrial appendage in determining stroke risk? It's not there. It's none of these risk factors. So that's when the picture starts getting dirty. We know that the CHA DS VASc score has been validated in atrial fibrillation. If you look at CHADS, which is the predecessor of the CHA DS VASc score, it did not include vascular disease and female gender. And CHA VASc, basically, the greater the score, the higher the risk of stroke. So that's great. And when we have a sufficiently high risk of stroke, we know that warfarin works. There's decades of studies that go back to the mid-80s and 90s that showed that there's a significant relative risk reduction of stroke when you take warfarin compared to not taking warfarin. And the new anticoagulants have all shown to a better job than warfarin. Dabigatran was shown in the RELY study to, at the dose of 150, to be superior at reducing the risk of stroke or systemic embolism. It was better than warfarin with less bleeding. Interestingly, and this is worth making a point here, when you look at the risk of stroke and you divide the strokes in ischemic versus hemorrhagic, it turns out that the risk of stroke was significantly decreased in warfarin compared to Dabigatran compared to warfarin, with a relative risk of 26% compared. So much better risk much better prevention of hemorrhagic strokes. When it comes to ischemic, it was a bit, basically almost crossed the unity line. So these drugs are better at preventing the iatrogenic hemorrhagic strokes that warfarin produces. And the same, very similar data for Rivaroxaban, better overall at stroke or embolisms compared to warfarin, but also did a better job at preventing hemorrhagic strokes. Event rate was a reduction of 40%, so hazard ratio of 59 of Rivaroxaban compared to warfarin. And then the actual risk of ischemic stroke was very similar across the unity line here. And finally, Apixaban also showed to do a better job than warfarin, preventing stroke or systemic embolism with less bleeding. And again, the similar story repeats itself. Equivalent rate of prevention of ischemic strokes compared to warfarin, but much better, almost 50% less hemorrhagic strokes. So these drugs do a good job as good a job as warfarin at preventing ischemic strokes, but lead to less bleeding in the brain, which is a big deal. And I don't need to go over details. One thing I need to emphasize is that these drugs, this is the way they work. They thin the blood. So it's unavoidable to have an increased risk of bleeding. With warfarin, outside clinical trials, it could be 6 to 8% per year, major bleeding. That means bleeding that leads you to get hospitalized or get a transfusion. In older than 80 years old, it can be up to 13% risk of bleeding per year. When you look at the clinical trial data, if you were to summarize everything we know about warfarin versus NOACs, this is a busy slide, but you can see the rates of ischemic strokes maybe a little bit less with the NOACs compared to warfarin. This is in 4 major trials. The risk of hemorrhagic strokes is consistently less with the NOACs compared to warfarin. Bleeding is less, particularly so with apixaban compared to warfarin, but it's overall less with the NOACs than with warfarin. Mortality was statistically significant with apixaban, but not with the others. Now, okay, so we have determined that our patient has a sufficient risk of stroke to warrant protection strategies. We're going to then give them a NOAC or a warfarin, and we just showed you that the evidence supports the NOAC as a first strategy. But again, going back to how do we know that a patient is going to benefit out of stroke prevention strategies, the CHA VASc score, what I want to emphasize here is that the CHA VASc score is non-specific. It's non-specific for appendage-driven risk of stroke. It's not even specific for atrial fibrillation. So we use this all the time to indicate blood thinners in AFib. If you look at patients that don't have AFib, and you look at their CHA VASc score, it turns out that it is just as good a predictor of bad outcomes. So this is a study that took patients with acute coronary syndrome, no AFib at all. And they look at the risk of MI, stroke, and mortality relative to the CHA VASc score. And it's just as good in a patient population as a predictor of bad things happening in a population that does not have AFib. So it is basically mechanistically non-specific. So going back to our approach to decide who would benefit from appendage closure or not, we need to think risk of stroke, like I said, and then what are the causes, specific causes of risk of stroke in our patient that we're trying to individualize. Do we have AFib-related risk of stroke or also competing non-AFib-related risk of strokes, such as complex plaque in the aorta or carotid disease. And then what is the benefit? What are the risks of stroke prevention strategies in our individual patient? Do we have a high bleeding risk that would prevent us from giving blood thinners? Do we have a high procedural risk that would prevent us from doing an appendage occlusion procedure? Is there a risk of hemorrhagic stroke, which could be lethal? And then we have to evaluate whether the patient may have benefit from anticoagulation besides atrial fibrillation. If the patient has had DVTs and had pulmonary embolism and they need anticoagulation, then this is a completely irrelevant discussion. They need to be on blood thinners. And also, of course, the previous patient experience with anticoagulation counts. If the patient has had major bleeding or bruises and has become an issue, or they have a high-risk profession that maybe make them prone to trauma, then we need to consider that when evaluating the risks. A few words about how mechanistically non-specific is the CHA DS VASc score. I have a patient here, two patients here, that have identical CHA DS VASc score. One in the left, both of them have a score of 5. This is a patient in the left that is 66-year-old, so she gets 1 point from being older than 65. She gets 1 point from being female. She's diabetic. She gets another point, hypertensive. They do a calcium score. She has a high calcium score, and she presents for cardioversion after she's had long-standing AFib for 2 years. And we do a TEE, and on the TEE, we find a clot in the appendage. She's never had a stroke, but we know that that clot in the appendage is a stroke in the making. So this patient has a high risk of stroke from AFib and a high risk of appendage-driven stroke. Now, on the right side, we have a patient with an equal risk factor of 5, 66-year-old, prior strokes, so he gets 2 points from that. Ischemic cardiomyopathy with heart failure, so another point. And the patient has extensive mobile atheromatous plaque in the aortic arch. Now, this patient gets bypass surgery, and then post-op day 2, patient goes into atrial fibrillation. They cardiovert chemically with amiodarone, and there's no more recurrence. Now, this patient has a high risk of stroke, but is it driven by atrial fibrillation? No, AFib was an anecdote. Is it driven by the appendage? No, we know there's plaque in the aorta. So closing the appendage of this patient, even though the CHA DS VASc score was 5, would probably be meaningless. And the interesting thing is a patient in the right here would benefit from anticoagulation, and that's proven by 20-year-old data from the SPAF investigators that looked at TE data in a patient population with AFib and high risk of stroke based on their associated risk factors. And in such patient population, they look at the prevalence of appendage thrombus or spontaneous contrast and compare that with the prevalence of complex aortic plaque. And they look at the prevalence was 30% for thrombus and 35% for complex aortic plaque. Whenever these two events happen, so patients, if you had thrombus or contrast in the appendage, your risk of stroke was triple the risk of stroke of patients that did not have that. If you had complex plaque, the risk of stroke was quadruple compared to the patients that didn't have it. The overall risk of stroke was 18% if you had thrombus in the appendage, and 15% or almost 16% if you have plaque in the aorta. And it drops significantly with warfarin. 75% reduction of risk of stroke if you had thrombus in the appendage, and a 75% risk of stroke reduction if you had plaque in the aorta. So what I'm trying to say here is that anticoagulation works for both. Appendage occlusion would only take care of these. So in the future, we're going to need to refine how we assess the appendage-driven stroke risk. And there's some data published out there looking at associations with particular anatomies of the appendage. The appendage is like your fingerprints, extremely variable. These are examples of human appendages. These are same species, I promise. And look how different the appendage morphologies can be. And it's been correlated very crudely, and I think non-convincingly, that if you have what is called a chicken wing appendage, this will be comparable with a chicken wing shape, you have less risk of stroke than if you have a non-chicken wing. I don't really buy any of this because this simplification of the complex 3D structure into chicken wing versus not chicken wing is completely crude. And the data was really retrospective. So I don't think this classification works, but I do think that the specifics of your anatomy determine the risk of stroke. That I'm convinced. So say we have decided to close the appendage. These are proposed gadgets. This is obviously potentially a very lucrative aspect of the industry of medicine. So there's a lot of companies coming up with gadgets to close the appendage of different designs. This is the Watchman, which is the one that has been studied in 2 randomized studies, and there are many other different gadgets at different stages of being developed and studied in clinical trials. I won't dwell into the details of the 2 randomized trials that compared Warfarin versus Watchman, but there's one slide summary that combines the data of 2 randomized clinical trials, and they compared Watchman versus Warfarin in a patient population with CHA DS VASc of at least 2. And when it comes to looking at efficacy, which was the combination of all stroke or systemic embolism or cardiovascular unexplained death, it's equivalent. So Warfarin was equivalent to Watchman. If you look at all stroke, virtually identical. It's basically in the unity line here. But it's very interesting because when it comes to ischemic stroke or systemic embolism, the Watchman did worse than Warfarin. The p-value is exactly 0.05, so it's not less than 0.05. And it touches the unity line here, but Warfarin did better than Watchman at preventing ischemic strokes. What happened was that Warfarin did a lot worse than Watchman when it came to hemorrhagic strokes, and 78% risk reduction of hemorrhagic strokes in the Watchman group. So the way I read this is that Watchman is very good because you don't take Warfarin when you have it. So you don't get the iatrogenesis of Warfarin. It turns out that the ischemic strokes are not as bad as the hemorrhagic strokes when it comes to causing death. Hemorrhagic strokes are far more lethal than ischemic strokes. So cardiovascular unexplained death was half in the Watchman group compared to Warfarin. All death touched the unity line here. Obviously, there was less bleeding outside the procedure, but if you count all bleeding, it was identical for Warfarin compared to Watchman. Let's look a little bit about bleeding in more detail. If you break the different times of the study, from randomization, doing the procedure at day 0 to 7 days, more patients in the Watchman group, in the blue, had bleeding than patients on Warfarin. Obviously, 1 week of Warfarin, you don't get a lot of bleeding. If you then look at from 8 days to 45 days, when the patients in both groups, Watchman and Warfarin, are taking Warfarin, because after the Watchman goes in, you need to be 45 days on Warfarin, you still get a little bit more bleeding in the Watchman group, perhaps delayed hematomas and stuff after the procedure. Then from 45 days to 180 days, the Watchman group goes on aspirin and Plavix, and the Warfarin group remains the Warfarin, obviously, and that's where the curves cross. And then what we call destination therapy, that means 6 months after a Watchman, you just go on aspirin, no more blood thinners. Then is when the Warfarin group has significantly more bleeding than the Watchman group that is simply on aspirin, 71% relative reduction. Now, this is great. At what price? Well, there are procedural risks, and it takes a fair amount of operator training. The main procedural risk is hemorrhagic pericardial effusion. Basically, if you tear the appendage when you deploy the Watchman, you have a tamponade that needs to be drained. If you're inpatient, you may need to go to surgery. Most of these stop spontaneously. But it is obviously a life-threatening procedural risk, and it was as high as almost 10% in the first half of the PROTECT-AF study. This is when operators were new to the procedure. They were learning. The company didn't even know how to optimize the procedural strategies, how to optimize the safety. So they were all learning, and they were interventional cardiologists and not EPs. So this is what happens, a lot of complications. Then sorry, I have to say that. So it's not really true. Half of the operators here are interventional cardiologists. And what we know is that not just procedural operator training, but overall learning from a collective experience, how we cannulate the appendage, how we deploy. We learn a lot now from understanding the anatomy. And in the last registry, it was 3.8. In the post-marketing data, it's actually as low as 2.2. So we can do a better job. But it's a procedure. There's no way around that. It's a procedure that requires instrumentation of the appendage. Okay, so we've learned the risks of blood thinners. We've learned the risk of closing the appendage. the third question that I wanted to have in mind when deciding which patient will benefit from from appendage occlusion, you have to think if there are benefits of anticoagulation beyond the appendage. And this is where it gets a little bit more speculative. But we know that in some studies, patients with atrial fibrillation, only 65% of the strokes could be classified as cardioembolic. So up to 25% of strokes could be related to intrinsic cerebrovascular disease, and the rest would be carotid disease. I guess they want. I'm almost done. I don't know if this is just a warning that I'm running out of time. All right, so there's some speculations that AFib may be associated with a procoagulant ischemic state. So that you have to keep in mind. So how do we make decisions? This is my last slide. There are patients that are clear. If you have a patient that comes with anticoagulation, typically someone on warfarin, you do a TE and they have a clot in the appendage, you know that patient has a higher risk of stroke from the appendage. It has failed anticoagulation in my book. A clot in the appendage to me is a stroke that in the making, and you need to do something else to get rid of the clot in the appendage, and perhaps a closure would be a good idea. NOACs remain the first choice. Warfarin is here to stay. We're not going to get rid of warfarin. There's patients that have financial constraints and cannot take NOACs, and if you have stable INRs, no bleeding, and good tolerance, warfarin is a perfectly good drug. Watchman would be considering patients that have bleeding, that have stroke on anticoagulation, so that's anticoagulation failure, that have poor tolerance to anticoagulants. Hemorrhagic strokes are particularly lethal. You don't want to have more than one of those. If you survive, if you're a good procedural candidate, this is a venous puncture procedure after all, and it's well tolerated. And if you have a high LAA appendage dependent risk, and I'll stop there. Thank you very much for your attention.
Great.